Welcome to Harlow on Healthcare. I'm David Harlow, and I invite you to join me by my virtual hearth as I sit down with healthcare leaders to discuss building the future of healthcare. Today, my guest is Jason Rose, CEO of AdhereHealth. Jason, welcome to Harlow on Healthcare. Thank you for taking the time to speak with us today.
Thank you, David. Look forward to the conversation.
So I'd appreciate it if you could give us a thumbnail sketch intro to your company, AdhereHealth, which I understand is focused on medication adherence. And I'd like to understand what angle you're coming at this from.
Absolutely. And thank you again for the opportunity, David. So AdhereHealth is a technology solutions-oriented company that is focusing on the $500 billion a year problem that the United States has in avoidable healthcare costs due to medication adherence. So our technology and our technology-enabled services focus on how we can resolve gaps in medication adherence, reduce the cost in care, and improve value-based reimbursement for government-sponsored plans.
Is that metric pretty well accepted, Jason? That's a big number, $500 billion problem.
Yeah, and it's actually bigger than that. The most recent study was in the Annals of Pharmacotherapy back in 2018, and their study was estimating over $528 billion. About 16% of the U.S. healthcare spend was attributed to avoidable medical costs related to medication adherence, and that was on 2016 data. So as the nation's population gets older every year, that number goes up every year, and unfortunately. So that's absolutely a real number, and they're not the only ones that have talked about that. I think 6-7 years ago, I think it was in the $300 billion range, but the most recent study is in 18.
This is a multifaceted problem, of course, and it touches on cost of healthcare, out-of-pocket costs for individuals, as well as the question of just remembering to take the pill, following instructions, the difficulties that people have in terms of actually absorbing all the information at the end of a medical visit. And we don't do a great job collectively on that front, though we have now the sort of end-of-visit summaries that are distributed. And I'm wondering what part of these problems, what constellation of these problems that get in the way of adherence are you addressing?
Yeah, and for clarity, that number is solely attributed to the avoidable costs. It does not include out-of-pocket costs that a consumer might have to pay for a particular drug. That would be a different number. This is
Understood.
actually the
Understood.
Yeah, it is the unnecessary cost. So, there are a lot of factors as you described. You mentioned the discharge summaries, the transitions of care. A patient goes to a hospital, that patient is discharged, and then back into the community. And then what happens from there? Does the primary care physician even know that the patient was in the hospital, or what medications were changed in the hospital? And does the hospital know what prescriptions that the patient was on when they entered the hospital? So all those different parts are one element of that, as you described correctly, which is the transitions of care. There are other issues as well, which are relating to social determinants of health, whether or not consumers have the ability to pay for the drugs. Then you go into other issues of health literacy. Do consumers understand the drugs that they are taking and why they're taking it, and what it's going to help with their diseases, which drug is helping for what? There are just a number of different problems that are attributed to the medication adherence problem. And I really do consider this a national priority for the country. If you think about nearly 20% of the entire U.S. healthcare spend is based on something that we can avoid. It really needs to be in the forefront of healthcare today.
So, Jason, what are you doing? What is AdhereHealth doing to tackle this problem? And how, I mean, there are a bunch of people in this space. I'm wondering what it is that you're doing and how that is unique or different from other approaches.
We take a very data-centric approach to how we tackle this problem. So our typical client is going to be a managed care plan. And if you think about why managed care plan is a really important aspect of this, is because they have so much access to the entire fulcrum of data that a consumer would have in the healthcare system. So they're going to have eligibility data of of whether or not the consumer is in the managed care plan, and then they're going to have all the pharmacy claims, all the medical claims, all the admissions and discharges, all the specialists that the consumer is seeing, and they have that, and it's in near real time in terms of as they pay the claims, they receive it. We are getting access to that data as partners with the managed care organizations. So we start with the data, and on a daily, nightly basis, we're receiving that new data in to identify where there are potential problems in cohorts of populations, and go right to the individual consumer and their doctor to identify what gaps there may be and what potential issues that might be causing those gaps. It could be a low-income subsidy patient that is in the zip code that shows that there may be some challenges in being able to pay for those drugs. It could be an access to care problem based on geo networking of where they have access to particular pharmacies or particular types of doctors to either pick up the drugs or actually be prescribed the drugs themselves. And all that data is poured through on our big data engine on a nightly basis, so that the next morning when our team of clinicians, which is about 600 clinicians, licensed clinicians across the United States and growing, pharmacists, nurses, nurse practitioners, pharmacy technicians, use that data in a clinical workflow platform to work directly with those consumers and their doctors to overcome whatever those issues might be. So I think the best way to describe this, David, is just in a use case example. So let's say that there is a managed care organization that has a very high amount of low-income subsidy consumers. So we know before we even start the engagement with the population cohort that there's going to be a lot of problems with access to healthcare, whether it be transportation, might be having access to food, may have shelter issues. So our clinicians are trained on the population cohorts of what they will be working with, so that when they actually get on the phone with the consumer and using our clinical workflow platform that's exposing all these medication adherence gaps, we're talking with them about real problems with respect to why they may be having some challenges. So what we're not doing on the first phone call is we're not starting with, how come you're not taking those drugs? What we're doing is we're asking them questions about, do you understand the drugs that you were prescribed and what they were for? And we ask them questions about their environment. Do you have food in your refrigerator? Do you have access to pay for transportation to get to your doctor? Do you have access to a pharmacy that's nearby? And we really focus on what I call the Maslow hierarchy of needs.
Sure.
For medication adherence is food, water, shelter. So if you don't tackle things like that before you actually get into the actual core of health literacy and medication issues, then you're never going to get ahead. So we take a very data-centric and case-by-case basis of how we can tackle this very important problem.
Well, that's a lot to bite off, and I'm wondering what's the feedback loop? How do you cycle back to your health plan customers or others in order to address these issues? So you identify the social determinants of health factors that are standing in the way. How do you then connect the patient with food, shelter, et cetera?
We see a very different approach in how we go about working with consumers. Is, if you're familiar with the term, I'm sure you are, with CRM. So our platform is built as a customer relationship management model, but we do it with each individual consumer. So we're not having one phone call with that consumer. We're having multiple phone calls, and each phone call we're addressing one item at a time. So we had an example a few weeks ago. The consumer was actually choosing her pets over her medication. So the consumer was not taking their drugs because she couldn't afford the dog food for her dog. So therefore, she was splitting pills.
Mm-hmm.
And what we did was we actually contacted some regional social area. We got in contact with the dog food company. Turns out there was a benefit where the dog food company would provide free dog food. So then the next phone call was ensuring that the dog food came, and then that was now tackled. What other issues did they have that were causing them to split pills, things like that? Once we tackled that issue, the consumer was now focused on her health versus her dog's food. And you could take the same approach if they didn't have food for themselves or food for their family. It really is a major problem. It's just food. And if you're not properly nourished or you don't have a safe shelter where you're living, then you're really not going to focus on medication. So we take one piece at a time, and over 4 to 5 phone calls in this particular type of use case is a low-income subsidy use case. We have plenty of others with commercial and other different types, but particularly with the low-income subsidy, may take 3 or 4 phone calls to finally get them to agree that they really do need that medication. And then we go about getting that medication delivered to them in an easy way. For example, we own a pharmacy, which is called AdhereRx, and as a great product for low-income subsidy consumer, they often don't have credit cards or an ATM card. They only have cash, and they may not have enough cash to pay for all the co-pays and co-insurances at the given time when they need it. So AdhereRx will use a private courier. We ship it to a hub. We have a private courier pick up the drugs to go to the local home of the individual, and we hand deliver it to the consumer or their caretaker, and we'll take cash on delivery, and we'll space out payments so that we can ensure that the patient is taking those drugs. We also help them with mail order programs and things of that nature too, whatever is their choice. But that's just one example of that. All that data comes in both into our platform and into ultimately into the hands of the physicians as well as the managed care organization. And we track all this from a performance management perspective to show whether or not that consumer has started to take their drugs adherently. And as I'm sure you're familiar, David, with the term of PDC, proportion-based covered, it's not enough that the patient took the drug once. They have to take it 80% of the year. Otherwise, the federal government and all the evidence-based guidelines don't determine you as adherent. So we have to not just get them on the drugs once. We have to keep them on that drug, call it a statin or a diabetic drug, or for hypertension, the RAS, things of that nature. We have to keep them on that drug for 80% of the year. Otherwise, they aren't considered adherent. And that's what we track.
If you are just joining us, this is Harlow on Healthcare, coming to you on Healthcare Now Radio. I'm David Harlow, and my guest today is Jason Rose, CEO of AdhereHealth. Jason, we had a little deep dive into one of your use cases, which is fascinating, and sort of the various tools that you need in order to really help someone be adherent to their medication program on a long-term basis. I am wondering if you could talk a little bit about the focus on medication adherence from the health plan perspective. I know that there's some Medicare metrics for health plans tied to medication adherence, and I imagine there are similar metrics imposed by health plans on commercial providers or through ACOs or through other mechanisms. I'm wondering how that plays into all of this, and again, sort of who is your customer in that scenario? Is it the health plan, or is it the ACO, or is it the integrated delivery system? You know, what's driving this, and where do you connect in?
Yeah, so our customer are ultimately those who are taking risk on the consumer's medication adherence issues. So clearly, it's really everything you just described. It's the managed care organization. It's the accountable care organization. It could be physician organizations who are sharing risk with the health plans. but they're all different examples of who our customers are. And if you think about one, I'll start with commercial, then I'll lead into your question on Medicare and Medicaid. So on commercial employer side, so as everyone's quite aware, there's a rising cost of care, rising cost of premiums for commercial members, and it's often or almost typically double-digit growth in premium costs for the employees. So the employers are going to their health plans and their TPAs and their PBMs, and they're saying, what are you going to do about this? I have to find a way to reduce the cost of care. And because of this very large $500 billion and growing problem of medication adherence, there are health plans that are realizing that the reality is it is about med adherence. And so they're looking for creative ways to partner with their physician network, as well as leverage their case management organization to work directly with doctors and the consumers to identify where these medication adherence gaps. They need the same analytics and technology workflow to address those problems. So if you think about Medicare Advantage, and most states, I think about 75 states that are managed Medicaid, also have similar elements, similar to the value-based reimbursement of star ratings that Medicare Advantage has put in place. CMS has put their money where their mouth is in terms of what they're focused on in value-based care reimbursement tied to medication adherence. So in 2018, data service, the reimbursement for a health plan, a Medicare Advantage plan, which is over 700 different health plan contracts, was over $6 billion available in a bonus pool if a Medicare Advantage plan would reach 4 out of 5 stars. And all the plans are graded against each other, as everyone knows, against dozens of different quality measures. And if they are one of the best, meaning that they're 4 out of 5 stars or higher, 4 or 4.5 or 5, then they will take part in that $6 billion plus pool, which is usually ends up being about $500 per member per year if they are able to improve to get to the highest star rating. And then that's public knowledge. Everyone knows that. What most people don't realize, and we put out an article on this in the American Journal of Managed Care recently, is that 50% of the actual weighting for the star ratings scoring is weighted on medication adherence. And that shows that CMS recognizes that $500 billion a year cost is that if you can increase medication adherence, you can reduce the cost of care. And therefore, CMS is going to incentivize the Medicare Advantage plans to focus on medication adherence so they can be one of the higher quality plans in the country.
Has that been consistent in the star rating over time, or my sense is that those criteria shift as different priorities at CMS shift over time? But has medication adherence been up there throughout?
Star ratings were put into effect as part of the Affordable Care Act back in 2010 timeframe. And as you and I both remember back then, it was more focused on process measures. So did the consumer get the blood sugar glucose test or not? Did they have this exam or did they not? And so you're right, over time, they have gradually started to weight the medication adherence focused measures to be higher weighted. So for example, RAS, statin, and diabetes medication adherence on the Part D side are all triple weighted. They've added new measures such as sub-D, which is statins with users with people with diabetes. Obviously you have MTM, medication therapy management in Part D. But the part that I think many don't think about until they uncover it is the Part C gaps. So you think about the Care for Older Adults, which is a medication review. And then you look at medication reconciliation post-discharge from a hospital. And then you look at statin therapy for patients with cardiovascular disease and the blood sugar glucose, A1C. So if you're not getting your medications done, or osteoporosis, another one, if you're not getting the medications prescribed and taken adherently, then you're going to not perform well on those individual quality measures. And so it's become a very big focus of the federal government. I'll give you really one great example of this is on the Part D side, you have the triple weighted diabetes measure. And on the Part C side, you have the HbA1c, which is also triple weighted, by the way. Well, what's changed over the last several years with A1C is that it used to be simply you just get the test done and you got credit. Well, now it's triple weighted and you have to be actually in control on the blood sugar glucose measure. And if you're not in control, then you failed the test. And the only way to really get them in control is if they take medications. So you go back to the consumer, is the right way to do this is think about the consumer holistically and get the consumer on the right medications, overcome all those social determinants issues. After about 2-3 months of the patient taking the right diabetic drug, then you order the test for the A1C. And each health plan has different ways of administering that. They may send a kit in the mail or help the patient go to a lab to get the test done. But you get the A1C test done after you've proven that the consumer appears to be on the drug. And then that consumer has a much higher likelihood of actually succeeding and being in control. If they're not in control at that point, well, then that's either the patient's hoarding the drugs or the drugs aren't working for them. So you can unpeel that part and understand what's happening there. Is the drug not correct or is the patient not taking them? They're just hoarding them and keeping them in the cabinet. But then at least you know now in that biometric testing. So all these things are very related, and that's my point of focusing on the consumer holistically in a CRM-like fashion is important.
And are the plans paying you on a PMPM basis, or is there any sort of risk sharing that you enter into, if you're able to discuss that?
Yes. We take different approaches depending upon clients of what they want to do. So some managed care organizations are very sophisticated and they have their own staff. They may have great relationships with the provider network, but what they lack is that clinical workflow tool. They may even have great analytics, but those analytics are not in a clinical workflow tool. So we actually sell what used to be our internal tools that we use only for our staff. We now sell that as a service, a SaaS, software as a service, to provide that to health plans. What I have really only seen out there in terms of a technology that is being used with most health plans is it's actually amazing, is Microsoft Excel and Microsoft Access databases are what's being used. So the analytics team does a great job in managed care organizations to create the analytics of targeting of who the consumers are. But when it gets put into how do you get a case manager or a doctor to go fix the issue, it gets thrown into an Excel table or an Access database, and then becomes very transactional at that point. And so if it takes 3 or 4 or 5 phone calls to get consumer adherence on the drug, because you have to keep them adherent 80% of the year, you really need that ongoing understanding of what you're dealing with at a case-by-case basis with the clinical workflow. And so we license that SaaS to our clients. We also will take a full risk tech-enabled services as well. So we'll each consumer one at a time, is that if we don't get them, for example, we don't get them to 80% PDC on diabetes, for example, then we don't get paid anything for that work with that consumer or their doctor. And so we take 100% risk on that particular conversion. If we don't get the consumer in control on their HbA1c, or the consumer is successfully becoming a numerator positive in the osteoporosis measure, for example, or the drug has not been prescribed by the doctor for SUD-D, the statin used for people with diabetes, we haven't seen that claim drop and get credit where the health plan is getting credit from CMS as a numerator positive, then we don't get paid anything. So what we find is that different clients have different infrastructure, and that may change over time too. Maybe they need some help in surge areas or time of the year where they need some help, or maybe they have a great team of people, but they just don't have the clinical workflow tool to manage those analytics, and that's how we contract.
So, Jason, to sum things up, my final question to you is this. If you were to wake up tomorrow and find yourself 5 years in the future, what is one thing in healthcare that you would hope or expect to be radically different?
I would expect and am wishful for that rising cost of unnecessary medical cost of $500 billion is not $1 trillion or higher because of the aging baby boomer population. And it's not going to be on some smart pill that you swallow that you can see if the patient took it or not. It's really, I think it's brass tacks. It's using the data you have available, using clinical workflow technologies like what we have. It's working one consumer at a time, empowering the doctors, empowering the case managers with data and workflow to do that. And I think that what I'm describing can absolutely be extended beyond even what we're doing today. So, for example, the big pharma market, for example, is struggling to get some of their higher cost drugs accepted within managed care organizations because the managed care organizations are worried about cost and whether or not it's effective. Well, the same exact analytics and workflow that I'm describing can be also used in the term I'm sure you're familiar with, which is outcomes-based contracting, OBC, where the big pharma company also now says, I will go at risk on this drug working with the health plan, and then we would be working with the big pharma as a facilitator with the managed care organizations to do exactly what I'm describing here, is get the right consumers, adherence on the right drugs. And that would also reduce that cost of the prescription and help out that overall community. And that's what I expect to happen. That's what I think is happening, hopefully less than 5 years from now.
Great. Well, thank you, Jason. You're holding out some great hope for the future here. Thanks for joining us today.
Thank you very much for the opportunity, David. It's great talking with you.
You have been listening to Harlow on Healthcare. Join us at healthcarenowradio.com. Let's continue the conversation on building the future of healthcare together at #HarlowOnHC. I'm David Harlow, keeping the fire going and holding a seat open for you. Until next time.